the next talk is on CAR cell therapy by Dr. Navaneet. So for which the moderator is Professor Jain from TMN. He's the right person to talk on CARs in India. So he's been the PI for many this CAR trials in India. So we get to listen of both sides of the world story. So over to you, Dr.
Good evening. Thanks, Dr. Shinto and the team at Baby Memorial Hospital for inviting us for this webinar. So Dr. Navaneet Majhail, he's a Deputy Physician in Chief of Blood Cancers for the Sarah Cannon Transplant and Cellular Therapy Network. He's also the Director of TriStar Sentinel BMT Program, past President of ASTCT, past Vice Chair and Professor of the Department of Hematology Oncology at Cleveland Clinic. And he has published extensively on the prevention and management of early and late complications of hematopoietic stem cell transplant and health policy of care, survivorship, and economic issues related to cellular therapy. On the panel, we have Dr. Rashmi Parasari. She's a consultant pediatric hematologist and oncologist from HCG MS Ramaya Cancer Center, Bangalore. Dr. Nishad Dhakte from Department of Hematology, Hemato-Oncology, HCG Nagpur. And Dr. Akanksha Garg, medical oncologist from GCRI Ahmedabad. So over to you, Dr. Navaneet.
Good evening, everyone. Thank you so much for this invitation. Really excited to be here. And I do want to start by congratulating Dr. Shinto and his team at Baby Memorial Hospital for setting up a new BMT program. Obviously, it's a big deal for your community. And I think in terms of access to these to treatment of hematological malignancies and the treatment of stem cell transplantation, I think it's certainly a big need, unmet need that will hopefully be achieved as you establish your team and go forward. So I was asked to give a high-level overview of CAR T-cell therapy, and I recognize and I understand we have a very diverse audience, which includes physicians, nurses, and a lot of other clinicians who may or may not deal with heme malignancies. So what I'll do over the next 20, 25 minutes or so is give you a very, very, very high level overview of what CAR T-cell therapy is. And I won't go into a lot of details and specifics, but happy to address anything in the Q&A session that all of you may have with respect to what the opportunities are and how this works. So with this background, maybe I thought what I'll do first is in 2 slides tell you about myself, where I work and what do I do. So, and thanks for the kind introduction. So I currently am in Nashville, Tennessee, which is this red dot here that I'm pointing at. And we have the Sarah Cannon network. So Sarah Cannon is the Cancer Institute of the Hospital Corporation of America, or HCA, that owns close to 220 hospitals in the US and UK. So we have a total of 10 BMT programs through our network that includes 7 in the US and 3 in the UK. And our network for transplants was established around 10 years ago. In fact, we celebrated our 10th anniversary this last year in October. And in 2021, we performed over 1,400 transplants and cell therapy procedures through our network just in the US. And even though we have programs that are located in very different, diverse locations, we truly work as one big transplant program with common pathways, common quality plans, the same supportive care protocols, and so forth. So with this background, let me start by talking about CAR T-cell therapy. So for many in the audience who may not know what CAR T-cell therapy is, in very simple terms, what we do with CAR T-cell therapy is we take your immune cells called T cells, we collect them by apheresis, and then they are genetically engineered to attack the cancer cells. And most of the work that has been done till date has focused in hematological malignancies like leukemias, lymphomas, and myelomas. Once those cells have been genetically engineered to express certain antigens that can identify those cancer cells, we can culture those cells, we can expand them, and then they're infused back to the patient. Now, most of the CAR T cells that are being used right now are autologous CAR T cells, so they're collected from the patient. And there is a lot of research going on in donor CAR T cells or allogeneic CAR T cells where they are collected from a donor and then obviously go through the process of this genetic modification before they are infused to a patient. Now, you might wonder why I'm talking about CAR T-cell therapy, and that is because conceptually, what we do here is very similar to bone marrow transplantation. So if you think about these CAR T-cell therapies, it's pretty much the same principle in the sense we are dealing with a form of a cell product where they are collected from a patient, they are modified, they are shipped, they are obviously cryopreserved, they have to go through a cell processing lab, and then we give chemotherapy for lymphodepletion typically, and then we infuse these cells back and manage toxicities which are very similar to what we see with BMT. So as a whole, as these CAR T-cell therapies are evolving, at least at the moment, they are primarily focused and being done through our bone marrow transplant programs in the US, Europe, and other places where they are more available. So obviously, there has been a lot of work done in this area for the last 3 or 4 decades, but this really took off around 10 years ago. So that is when, and again, what I show here was not the first clinical report of the use of CAR T cells for the treatment of cancer, but these reports, the report I mentioned here, which focused on the use of CAR T cell for the treatment of relapse refractory ALL, acute lymphoid leukemia, really caught people's attention because it described 2 young girls, 2 young kids who had refractory relapsed ALL, who were essentially put back into remission with the use of this CAR T cell therapy. Now, obviously, in that context, one of the girls that you see here, her name is Emily Whitehead. Her parents have organized a foundation called the Emily Whitehead Foundation, and she is now 10 years out from that treatment and has almost become the face of this CAR T cell therapy, and rightly so, because it did take a lot of courage for her and her parents to enroll her on that clinical trial. So obviously, since the early reports around 10, 12, 15 years ago of the use of CAR T cell therapies in a clinical space, there has been an expansion of many of these therapies in a variety of heme malignancies, solid tumors, and now we are looking at indications in the autoimmune space as well as infectious diseases as well. Now, in the US, we have at least 6 products which are being approved by the FDA, the Food and Drug Administration, that we can use commercially. In addition to that, we have a plethora of clinical trials that we use as well, using these CAR T cell products as well as other cell therapies. So among the 6 products that we have available in the US for treatment of patients with hematological malignancies, we have Tisa-cel or Tisagen-like-Leucel or Kymriah, which has an approval for patients with pediatric ALL as well as adults with lymphoma. Then we have Axi-cel or Brexucabtagene Cellular, which is approved for the treatment of patients with relapsed refractory large B-cell lymphomas as well as follicular lymphomas. Then we have Brexucabtagene Maraleucel, which is approved for the treatment of patients with large B-cell lymphomas. We have Brexucabtagene Autoleucel, which is available for the treatment of patients with refractory mantle cell lymphoma. And then we have got 2 products now, Idecabtagene Vacleucel and Ciltacabtagene Autoleucel, which are available for the treatment of patients with relapsed refractory multiple myeloma. The one common thread across all of these products is that they are at the moment approved for the treatment of patients with highly refractory, highly treatment-resistant diseases. So this is not for upfront treatment. This is not for second-line treatment, at least in a commercial space as yet, although trials are being conducted in that setting. But again, at the end of the day, I mean, these are available for treatment for our patients here in the US and in some countries in Europe. Now, the one thing I do want to emphasize and talk about is the fact that this is where our transplant field is heading as a whole. So as you think about the vision for the field in the next 5 or 10 years, I think we'll be doing as many transplants, maybe less transplants than what we do right now. But some of the patients we transplant for right now will go on to receiving these cell therapies in the future. And I think as a field, as a BMT program, because most of these cell therapies, I think, will happen in BMT programs. And as the field evolves, I think we'll be seeing more indications for these cell therapies as well in the solid tumor space, like breast cancers, colon cancers, other solid tumor malignancies as well as indications outside transplant, such as such as autoimmune diseases and infectious diseases for that matter as well. And again, I recognize these therapies are not available in India as robustly as what we see in the West, in Europe and the US. But I do recognize, and it's nice to know that our panelists are from our experts who are working on some of this area through their projects at Tata Memorial, IIT, and others. So again, hopefully there will be some of these therapies available in India more widely in the near future. Now, one of the things I'll mention here, which is a problem because that is what limits access to these therapies, not just in countries like India, and also in countries where they're already available, like the US and Europe. So in the US, these commercial products cost anywhere from $400,000 to $500,000. So if you convert them, that's almost like 3.5 to 4 crores rupees just for the product itself, plus the care you need to get these patients through these therapies. So obviously cost is a huge barrier. And I think that is where there's a lot of interest in trying to have some indigenous products or off-the-shelf products or products that can be manufactured locally, institutionally, to try and circumvent the issues with the cost of these therapies. I'm going to have a step back a bit, because again, I recognize we have a diverse audience, which may or may not be very familiar with BMT, and may not understand some of the nuances of why these CAR T cells are used. So I'm going to take us back. And talk about the rationale for using these CAR T cell therapies. So in 2 or 3 slides, I'll talk about the immunology and the mechanisms behind it. So we all have immune systems, and our immune systems are primed to prevent exposure to and impact to our bodies by infections and cancers and any other noxious stimuli that we might get. Now, one aspect of the immune system is what we call T cells or T lymphocytes. These T cells tend to be very potent. They're very potent at attacking cancer cells, for instance. And as our bodies develop cancers, one of the things those cancer cells try to do is they try to get around this immune surveillance. So they try and get around this immune surveillance because if your body has a robust immune surveillance mechanism, it is going to prevent those cancer cells from coming up and proliferating. Now, I will not go through this slide in detail, but this just outlines some of the mechanisms that our body has or these cancer cells employ and develop over time as they become more resistant and evade the tumor immune surveillance mechanisms that our body has in place. Now, again, these T cells are very potent. They're very potent in killing cancer cells. So, they have a variety of mechanisms through which they cause cytotoxicity, they cause cancer cell kill. But the problem with these T cells is you can have a cancer cell sitting right next to it, but they wouldn't know what to do. So what they always do is they have mechanisms or they need help to find the cancer cell and then attack it. Now, most of our body cells, they express what we call MHC or major histocompatibility complex. And what the T cells do is they have these T cell receptors that recognize these MHC molecules and tell this T cell, is it a self cell? So is it a cell they need to just let be? Or is it a cell that is not self and they need to go and attack it? And what these cancer cells do is they learn how to modulate this MHC. So they may not express it at all, or they may change it so that the T cells don't recognize that. So again, these T cells needs the help of something else to help them identify those tumor cells or cancer cells where they can achieve cytotoxicity and kill them. Now, what happens with a CAR T cell product, and again, guys, this is science fiction. This is science fiction because we are generating a cell that does not exist in nature. So what happens is we use a viral vector, typically a lentiviral vector or a retroviral vector. And what we do is we use that vector to incorporate a certain amount of DNA into the T cells. And what the T cell does is it starts expressing these CARs or chimeric antigen receptors. And what these CARs do is they help the T cells bypass the need for that helping mechanism to identify cancer cells. So what these CAR antigens can do, receptors can do, is they can identify those tumor antigens directly without needing the help of anything else. And once you can do that, obviously, once they identify a tumor cell, it leads to a T cell activation, it leads to the release of cytokines, and that is what ultimately leads to tumor cell apoptosis. One of the key constructs of this CAR is this receptor, what we call the chimeric antigen receptor. Again, I won't go into a lot of details today since I want to keep this talk high level, but essentially there are two aspects of this CAR which are really important as we think about the innovations happening in this field, right? So we have what we call the antigen binding domain. So this part is what identifies the cancer or tumor antigen, and with the technology that we have, with that viral vector that we introduce into the T cell, you can have the T cell basically express any antigen binding domain that you want. So again, I'll show a slide later, but that is why there has been an expansion, a tsunami of these trials looking at CARs for a variety of mechanisms, a variety of tumor types and other diseases. Because now you have the technology. I mean, the limit is your imagination. If you have a good antigen on a tumor cell, you can express a CAR against it. And most of the work, as I showed earlier in a slide, most of the diseases where we have CAR T cell therapies at the moment, they're all B cell malignancies. So they're all targeted mostly towards CD19. But as the field is evolving, as we go from what we call first generation to second generation to third generation CARs and beyond, people are looking at modifying the antigen binding domain to look at a variety of receptors on many different tumor types. Now, to increase the efficacy of these CAR T cell therapies, investigators are looking at CARs with multiple antigen binding domains. So for example, in the context of B cell malignancies, instead of just targeting one antigen like CD19, can you have dual CARs, for example, that target CD19 and CD22, which would increase the chances of long-term efficacy? Then again, a lot of innovations happening in the activation domain as well, because what happens here determines your risk of side effects and toxicity. We'll talk more about that. And it also determines how long these CAR T cells stick around in your body, because the longer they stick around in your body, the more likely they'll control your disease long term. So again, I highlight the construct of the CAR, the chimeric antigen receptor, because this is where a lot of the innovation and research is happening. And I think as people go from different constructs and different generation of CARs, this is where the changes happen as our investigators try to improve the CAR T cells that are currently being used. Now, over the next 3 or 4 slides, I'll give you some examples. I'll give you some examples of studies that have been done in this area. Again, I mean, there's no way I can cover everything in 20 or 30 minutes. Just want to show you some of the pivotal representative studies that have led to the approval of these products in the US for these indications. So this is an example of Autoleucel or CTL019, what is now called Kymriah. So this was a study that focused on pediatric and young adult ALL, acute lymphoblastic leukemia. And keep in mind, all these studies I'll show you and talk about over the next 2 or 3 slides. Again, as I emphasized before, these are all focused on heavily pre-treated patient populations. So typically, the survival for these patients is less than 10%. So those of you who do hemato-oncology, you recognize that patients who failed 2 or more lines of therapy with ALL patients who fail 2 or more lines of therapy, I mean, their median survival is in the range of months. So obviously a highly treatment refractory patient population. In this setting, and again, in this study, half of these patients had failed a prior transplant. So they had an allogeneic transplant and had relapsed following an allogeneic transplant. So in this very high-risk pediatric patient population, they found a CR and CRI. So CR is complete remission, so getting your leukemia into remission, and CRI is basically complete remission with incomplete count recovery. So you do a bone marrow biopsy, your leukemia is in remission, but your blood counts haven't recovered as yet. So in this heavily treated patient population, your response rate was CR rate was close to 83%. So it was 83%, which is quite incredible. And the majority of these CRs were MRD negative. So MRD is minimal or measurable residual disease. So this is using sophisticated tests like multi-parametric flow cytometry or next generation sequencing to find very, very microscopic, minute amounts of tumor, leukemia in your bone marrow. And the thought process is if you can get patients into an MRD negative state, you increase the chances of their cure and long-term remission. So this is a desirable state in many of our leukemia patients who we treat with treatments, including transplant. So again, a pretty high rate of MRD negative state in this very high-risk patient population. Now, another study that was done in adults, this is using Brexucabtagene, Autoleucel or Tecartus, as we call it now. Again, the same result. This is in adults with relapse refractory B-cell pre-B-ALL, and 67% of patients had failed more than 3 prior therapies, and a third of patients had undergone a prior allogeneic transplantation. And again, in this setting, if you look at the complete remission rates, both CR and CRI, these were close to 70%, again, highlighting how effective these therapies are, and also a pretty high rate of MRD negativity. Now, switching gears, this is Axicell or Brexucabtagene data. This was a ZUMA-1 study that led to its approval in the United States and in Europe. This was patients who had failed at least 2 or more lines of therapy for large B-cell lymphomas. So these were patients with relapse refractory lymphomas, and the overall response rate was 72%, with half these patients achieving a CR. Now, what this figure here shows is the 2 reports, one showing the results for Axicell. The second panel on the right side shows results for Tecartus. And what I want to highlight here is what these survival curves indicate is that at a year or up to 2 years, almost 40% of these patients were hopefully cured of their relapsed refractory lymphomas. Now, if you think of this patient population who was considered on this trial, who had not gotten CAR T-cell therapies, again, there are no head-to-head comparisons, but if you look at, so there was another study called the Scholar study that put together these data, and that is what they compared the outcomes of the Axicell to. So a comparable group of patients who did not get these therapies, you can expect 2-year survival rates of 10%. So again, you can argue 40% is not a big improvement, but still it's quite remarkable if you consider the patient population that was considered here. And we all recognize that these therapies are slowly moving in trials to a more proximal setting in the treatment space. So instead of being considered as 3rd or 4th line therapies, they are moving up to the 2nd line therapy space. And we hope to expect better results in that setting. And in fact, at the ASH meeting this past year, the American Society of Hematology meeting in December, investigators presented the result of the ZUMA-7 study, which looked at Brexucabtagene Cellular or Axicell in the context of 2nd-line therapy for relapsed refractory B-cell lymphoma, and showed almost 70% PFS at 2 years. Now, just 1 or 2 slides on multiple myeloma, because there's a lot of interest and activity in this area. And myeloma is unique because unlike B-cell lymphomas, where you only have a few antigens you can focus on, you have a plethora of more antigens you can target for myelomas. And one unique antigen is what we call BCMA, or B-cell maturation antigen, which is very prime for CAR T-cell therapy because it is almost exclusively expressed on plasma cells. You don't see BCMA on other normal healthy cells. So that is why a lot of interest has focused on this specific antigen. But obviously, I mean, there are all these other antigens that are being investigated in other CAR T constructs and products on clinical trials. And again, I think while we're on this topic, just want to highlight that as investigators, and we'll look at what is a good antigen for CAR T-cell therapy. I mean, we try to shoot for antigens that are not expressed in normal tissues. And I'll come back to this more as we talk about the toxicities and side effects. And hopefully they don't share an epitope with normal molecules. And the CARs we produce typically have a good affinity for these receptors. And that's one of the reasons sometimes these CAR therapies don't work in all tumor types, And obviously, we don't want this to be easily shed or downregulated, because what cancer cells can do is they can say, all right, we'll stop expressing an antigen. So for example, B cells, once they get exposed to CAR-T, might say we won't express CD19 at all. So they down-regulate CD19. And that is what sometimes leads to recurrence or relapse after treatment with these CAR-T cell therapies. Data with the CAR-T cell therapies for multiple myeloma are pretty spectacular. This is the Legend-2 study, which looked at ide-cel or Idecaptagene. So this was patients who were triple refractory. So patients were required to have failed treatment with an IMiD, so Revlimid or pomalidomide, failed treatment with a proteasome inhibitor, so carfilzomib or bortezomib, and were required to have failed treatment with daratumumab, the anti-CD38 antibody. So a highly treatment refractory patient population. So for those of you who treat myeloma, I'm sure you recognize that the median survival for this patient population is 8 to 10 months. And in this patient population, the overall response rate was 97%, with a stringent CR rate of 67%, and what I would call a good CR, which is a CR and VGPR rate of 92% or 93%. So again, pretty remarkable. The only challenge is the remissions are not sustained. So most patients the median duration of remission was roughly a year or so in this context. But again, having treated patients on trials with these therapies, I think given how refractory relapse they are just glad that they don't have to need any treatment for that year and a half that they've been off therapy for that matter. And as I mentioned before, a lot of interest and activity in trying to modulate these CARs to cause more sustainable activity of these CARs long-term in vivo in patients. Just a slide or two on toxicity, because these novel therapies also come with some unique toxicities. One of the toxicities that we always look for is what we call cytokine release syndrome. Which is basically, for those of you who don't treat these patients or, don't do BMT, it's almost like going into shock. So these patients have hypotension, they'll go into respiratory failure. They'll need intubation, ventilation, and they get high-grade fever. So it's like a cytokine release syndrome where these T cells, as they activate, they release all these chemicals and cytokines, which leads to an inflammatory immune response within your body. So when we treat these patients, we are on the lookout for this. Anytime we see this coming up, so early on, we give this IL-6 inhibitor called tocilizumab to try and cut down the chances of this getting severe. Then there is a toxicity called ICANS, or immune effector cell-associated neurotoxicity syndrome, where patients will have delirium, aphasia, seizures, and can even have cerebral edema. And again, quite remarkable. You may have a patient who is talking to you in the morning, and by evening, they're obtunded, and you treat them with high-dose steroids, and they're up and okay the next day. So a pretty remarkable toxicity that we see in this setting. And then there's the concept of what we call on-target off-tumor toxicity. So it's called on-target off-tumor toxicity, where your CAR goes and hits the right target, but that target is not on the tumor cell, it's on a normal tissue. So for example, with the CAR-T cell therapies we use for B-cell malignancies, many of our patients have prolonged hypogammaglobulinemia. So they don't have any B cells, because what these CARs do is they also eradicate your healthy B cells. And one of the challenges why this is not taken off in acute myelogenous leukemia is because targets like anti-CD33 or other antigens in the context of AML are also heavily expressed on normal myeloid cells. So if you use a CAR against AML, that will typically wipe out the myeloid compartment of your bone marrow for a long period of time, which obviously becomes very dangerous and lethal. So this slide just highlights some of the ongoing research, both in the heme malignancy as well as the solid tumor space. Again, as I mentioned before, I think the technology has evolved where if you can, as I mentioned before, your imagination is a limit. And I talked about what we look at as you think about a good antigen to target a CAR against. But if you can find a good target, which is actionable, is not expressed on normal tissues, I mean, you can potentially develop a CAR against that target. So a lot of research happening in this area. So this is my last slide. And as we think about where this field is going, I mean, I think there'll be more demand. I recognize that in India, this treatment is not widely available. But I think Dr. Shinto wanted me to give you a primer because he knows this is coming in the next 5 years in India as well. You know, as you work on your indigenous products, as the technology works on making these CAR T-cell therapies more accessible and cheaper as well. And as people look at off-the-shelf CARs as well, where you don't have to go through the process of production, you know, collection, and then waiting 3 to 4 weeks before you get it back. And as the field evolves, I think we'll have safer products as well. And we already are seeing safer products, which we can now infuse in the outpatient setting as well. But then again, I talked about the cost issues, which have to be addressed as we go forward. And obviously some of the production issues that come with this. Again, I didn't talk much about that, but there are issues with the availability of enough vectors to generate these CARs, as well as the quality issues, the regulatory issues that come with this. So again, I know this was a very, very high level overview of CAR T-cell therapy that I wanted to share with you. Again, recognizing the diverse audience we have today for this presentation. And my heartiest congratulations again to Dr. Shinto and the team at Baby Memorial Hospital for setting up your BMT program. Looking forward to great things from you guys. Thank you very much for your attention.
Thank you, Dr. Navaneet. I mean, if there are any questions from the panelists or from in the chat box, we will take them.
Hello, sir. This is Dr. Nishad here. Thank you for that lucid presentation. I wanted to ask, what about patients who have MRD positive CAR T-cell? Do you offer them some other treatment?
So are you asking about MRD in the context of ALL?
Yeah, MRD in the context of ALL post CAR T-cell therapy.
So that's a good question, right? So I think so. What you just for the audience, just to frame this question, I think what you're trying to get at is what are the potential treatment options after CAR T, whether patients are MRD positive or MRD negative, right? So now you have to recognize that these CAR T cell therapies that we're using in the context of ALL at the moment, they are typically being done in very high-risk patient populations, right? And as you know, I mean, MRD has a limit of detection. Doesn't mean you've eradicated all tumor cells. And at least in the context of AML, irrespective of your MRD status, if patients are candidates for an allogeneic transplant, you know, I think the preference is to take them for an allogeneic transplant after the CAR T-cell therapy. Now, what do you do in the context of someone who is still MRD positive after a CAR T-cell therapy? I think that area is very controversial, right? That area is controversial. So again, a couple of comments there. One is the rate of MRD positivity in patients who go into a CR after CAR T is very high. So almost 80–90% of those patients will achieve MRD positivity. Now, if you have received a CAR T-cell therapy and you're still MRD positive, I'm not sure what the right answer to that is. I think historically we know if you do an allogeneic transplant in that setting, you know, there's a high rate of treatment failure. And I think it all depends on what the patient situation is. If they have not received other therapies like blinatumomab before, I think my preference would be to get them into an MRD negative state and certainly proceed with an allo transplant, because if you fail CAR T, you haven't achieved MRD negative status following CAR T, you obviously have a very high risk of relapse. So if you can get them into an MRD negative state, I would certainly proceed with an allogeneic transplant. And I think some of my colleagues might argue if someone has not had an allo transplant before, they're still MRD positive, and they are young, robust. I mean, and you are going to use a myeloablative conditioning regimen, you might still make a case for moving ahead with a transplant in that setting.
Thank you,
so long answer, and as you guys know, the longer the answer to a question, the more controversial that area is.
Dr. Navaneet, I have a question. So there is, with the stem cell transplants in India, there's a great supply and demand mismatch. And that too, because each of this is located in specialized centers, you need resources to be set up at each center for the manufacturing. I mean, the FRSs, the cryopreservation, So you need specialized personnel, trained nurses, trained transfusion medicine guys. And of course, the bottleneck is the availability of beds for the transplants. And so that's why we've not been able to succeed there. Now, given that cellular therapy, at least the humanized ones, have lesser toxicities and probably could be given as an outpatient therapy, do you think making them, creating a centralized manufacturing facility can allow it to become more democratic, make it accessible to a larger number of patients as compared to the transplants?
Hasmukh, you're spot on. I think that is where the field needs to go. And I think that is where it'll go over the next 5 or 10 years, right? And this is a problem, not just in India, it's a problem everywhere, including the US. And I think in the US, the issue we're facing is as we get more of these therapies in a clinical space, let's take the example of multiple myeloma, right? So, I mean, we've got all our transplant programs are getting busier and busier. So I can tell you, I mean, I run 10 BMT programs, right? And we don't have capacity right now to take care of all these myeloma patients that will come through over the next 2 years for these CAR T-cell therapies. I mean, you can't build these beds fast enough. You can't train these nurses fast enough. You can't have enough doctors, pharmacists, and other people trained and ready to take care of these patients. So I think if we have to do this in a robust way, there have to be mechanisms where this has to be done outside these specialized centers for that matter. Now, having said that, I think our specialized programs like our BMT programs and whatnot do have a big role to play in this, right? Like you said, it has to be a centralized mechanism where you take the expertise of that center. I mean, there's no point in putting up production centers everywhere, right? I mean, you don't need to have an apheresis facility in each small, practice, if you will. So how do you use creatively the infrastructure that you have at Baby Memorial Hospital and work with centers which might be 2 hours away, 3 hours away to provide these therapies there? And again, I think I just want to remind people, I mean, if you think about BMT, right? If you think about BMT, what we do is, I mean, we have all these protocols, I mean, we have all these studies, we have all these quality mechanisms, right? The reason we have that is not for those 99 out of 100 transplants you'll do, because they'll all happen the way they're supposed to, right? The reason we have this specialized team is for what I call that shit hits the fan moment, right? With cell therapy, stuff happens. There'll be, there'll be a puncture in a bag, right? So it'll break, right? Your cold chain storage, the cold chain piece will break at some point in some product, right? So a donor will fall through, right? So stuff happens. And that is where having a team that has experience, has all the right infrastructure comes in. And I think that is where, how do you creatively come up with centralized models where you use the expertise of these specialty centers and then try and push this out to your other collaborating practices that can help you with this, because that is how you increase access.
Yeah.
Dr. Majhail, Rashmi here. Great talk. In going in line with what Dr. Hasmukh just talked about, having centralized manufacturing facility, what is your opinion on like universal T cells, like allo T, universal CARs rather than each patient directed CAR?
Yeah, that's a good question, Rashmi, and obviously, I mean, for the audience, who may not understand what universal CARs are, I mean, you're referring to what we call allogeneic or off-the-shelf CARs, right? Yes, off-the-shelf CARs, not universal CARs. So what off-the-shelf CARs? So what we've talked about and what is available right now, you have a patient, and again, I'm giving this background for the audience here who may not know what off-the-shelf CARs are. So right now, as I mentioned before, you have a patient, hook them up to an apheresis machine, you collect the cells, those cells go out to a production facility, and then those CAR Ts you produce are specific for that patient, right? You have a CAR T that is produced that is specific for that patient. And you can't use those CAR T cells for anybody else, right? Because, if you give those T cells to somebody else, you'll end up getting graft versus host disease, right? So that is why you can't use those cells for anybody else. And what you're asking about is what we call biobanking, right? You look at CAR T cells from donors, healthy donors, and then you bank them. You need a CAR T cell, I push a button. I'm trying to make it sound very simple. I push a button on my laptop or computer, order goes out to the company. They say, all right, this is Navaneet wants a T cell for CD19. I'm going to ship it out to him here. It's in your center tomorrow. You infuse it the day after, right? So there's a lot of enthusiasm and interest in that area for a couple of reasons, right? One is, you're right, it cuts down the need for this production piece, right? It's already banked. And just for the audience, one of the reasons you can do it is because the technology that is out there with the technology, and especially, I mean, we didn't talk about CRISPR and whatnot, you can slice off the T cell receptors from these T cells, right? So you can slice off the T cell receptors from these T cells where, I mean, all these T cells, CAR T cells do is they express those CARs, and they're not as immunogenic for other stuff that causes graft versus host disease. So there are a lot of advantages to this, right? I mean, one is they're available right away, right? So you don't have to wait for 3, 4, 5 weeks to have them manufactured and do it. And the other big piece that folks feel is an advantage of these T cells is they're from healthy donors. So one of the things that happens in patients with leukemias, lymphomas, myelomas, who have been treated so much is often these patients have what we call T cell exhaustion, right? Their T cells are not fully functional, they're dysfunctional, so they don't work as well, right? So in that context, if you can take healthy T cells, the idea is they'll hopefully work better. So a lot of interest in off-the-shelf CAR T cells, but I mean, there are trials going on, and we have trials here in Nashville through our network as well, but we have to look at the data and see what happens.
Thank you.
Yeah, Dr. Majhail, thank you so much for your talk. I'd like to ask you whether CAR T cells, are they effective in treating patients with the advanced CNS disease as well as extramedullary disease? And post the CAR T cell therapy, how do you monitor the effectiveness of the CAR T?
Yeah. So great questions, and you guys are making it hard for me with all these hard questions you're asking me. Okay, so if you look at the initial trials, let's just focus on lymphoma and leukemia, right? Because that is where, and more so, let's focus on ALL, because lymphoma you don't see as much of CNS disease. Although, I mean, you have a patient with CNS lymphoma as well. I mean, that have been treated often on trials. But if you look at ALL, they required your CNS disease to be totally treated. So you were required to have CNS negative disease before you went on those trials. And the same thing with lymphoma. Patients who had known CNS disease were excluded from the trials, the pivotal registration trials, Zuma 1, Juliet trials and whatnot. Now, having said that, since those initial trials, there have been retrospective studies. Okay, so there are no good clinical trials in this area. There are retrospective studies where people have given these CAR T cells to patients with active CNS disease, and they found responses. And there is preclinical data that does show that these CAR T cells do cross the blood-brain barrier, and you can find them in the CSF. Okay, so again, I think as we go forward, I mean, these are being used in certain situations with active CNS disease. Although I think that since this is an unknown area, if we have a patient with ALL who has CNS disease, our preference is to try and get that patient into a CNS negative state, intrathecal methotrexate and Ara-C, and eradicate that disease before we bring them in for the CAR T cell therapy. Because again, keep in mind, we also recognize more the amount of disease you're dealing with, the less efficacious those CAR T cells, right? And the more the toxicity, you'll see more CRS in that setting. Okay, so that is where we do try and eradicate that disease if we can. Regarding the efficacy question, a lot of unknowns. A lot of unknowns. No one knows, because people have these assays, for example, where they can track these T cells, but they're all research, right? So in the context of B cell malignancies, right, where most of these patients are being treated right now in the commercial space, the standard of care space, we have the poor man. We have the poor man way of tracking a response and how long these CAR Ts persist, and that is your lymphocyte count, right? Because lymphocyte count is very low. I mean, that there is some of these CAR T cell persistence going on, because, like I said, normal B cells, they express CD19, right? And if you've got some CD19 CARs hanging around, I mean, very likely that's why you're having that lymphopenia as well, right? And that's why you see that low count. Now, one caveat here, and this has been shown as well, with some of these constructs, again, like I talked, some of the innovation that's happening is how do you make these CAR T cells persist long-term? But there are situations that people have looked at this. Sometimes you give the CAR T cell therapies, they'll be there for a couple of weeks, and then they go away. You don't find them anymore. But these responses continue long-term, right? And we don't know why that happens.
Okay. And do you routinely do bone marrow examinations also to see for the persistence of CAR Ts in the marrow?
No, so there's really, I mean, in a clinical care setting, there really is no way to identify these CAR T cells in the bone marrow, right? In the research setting, you can. I mean, again, you would flow the marrow to find those CAR T cells, right? So that's what you would do to identify them. But again, it's a research test. It's not something that's happening in the routine clinical space.
Thank you so much.
Dr. Majhail,
Yeah, sorry, please go ahead.
sorry about that. So do you choose between the co-stimulatory, domains like CD28, 41BB, CD137? Do you have a choice, or each? How do you compare them? Is one better than the other?
So again, good question. And just to simplify this for the audience here as well, I mean, what you're asking about is the co-stimulatory domain within the CAR T cell, the receptor itself, right? And if you go back to the figure I'd shown, this was the domain which was right, as you went into the cell, the activation domain, that's where that is. And what this determines is two things, right? So one is the toxicity of those CAR T cells, and the second piece is how long do they stick around, right? So again, all the products that we have in the commercial space right now, I mean, that's where they differ. They have one co-stimulatory domain versus the other. So again, to be honest, I mean, I don't think we differentiate on. So let me step back a bit here, and goes back to what Hasmukh was saying. Even in the US right now, I mean, we have production issues, right? So if we have a patient with refractory diffuse large B-cell lymphoma, very often I may not have the luxury of saying I'm going to use a specific CAR because there's a better CAR, for example. One, there have been no head-to-head comparisons between Axi-cell, Tisa-cell, and Liso-cell. Although I think the general anecdotal experience is that Axi-cell and Liso-cell may be a little bit more effective than Tisa-cell, if you will. But a lot of times it's a patient with bad lymphoma. I mean, you move ahead with the best product that you can that's available right away. So I don't think we have the luxury at this point of trying to choose, which CAR we use based on some of those specifics of the CAR receptor itself. But hopefully, I mean, I talked about second generation and third generation CARs. I think as the field evolves, I think some of these things that we have right now will go away because we recognize they are not as efficacious or cause more toxicity compared to some of these other constructs that are coming down the road.
Thank you so much.
Sorry, there's one question on the chat box. Where do you see the future of refractory T-cell malignancies?
So where do we see the future of refractory T-cell malignancies? So if you're asking in the context of CARs, I mean, they are being, so one of the things that is being investigated in the context of T-cell malignancies is CD30, right? So you can find CD30 in some of these T-cell malignancies as well as Hodgkin's disease. And we have trials open here, which are looking at some of that. So again, I think one of the take-home points that I want you all to keep in mind is as the field evolves, right, and as you start doing more of these products and these therapies in India as well, going forward, I mean, we are scratching the surface here, guys, right? There are so many questions unanswered that we have to address, right? I mean, they're all, I mean, which are the right candidates? What's the right construct? I mean, you can talk about things like checkpoint inhibition, right? I mean, how do you use that to potentiate the efficacy of these CARs as well, right? So, I mean, I think in the next 5 or 10 years, this field is going to explode. It's already exploding. I mean, again, like I showed, there are like 600, 700 trials happening worldwide right now, with a variety of these CAR T-cell and other cell therapies. And keep in mind, these are basically, again, with the CAR T things that we're doing, this is a proof of concept, if you will, right? I mean, again, if you think at cell therapy, I mean, we're just starting off right now. So I'll give an example. One of the clinical trials that we have currently at our institution, it is looking at a CAR NK construct or a CAR NK product. And for those in the audience who don't know what NK cells are, these are natural killer cells. And unlike T cells, so NK cells are a part of your innate immunity, right? So NK cells will destroy anything they see unless that other cell can tell them, hey, stop, this is, I know you, we are supposed to be friends, right? So these NK cells are very effective in killing cancer cells because, I mean, those cancer cells often don't express, that self-antigen. But the problem is these NK cells, they only stick around for a couple of days. right? So the construct that we have in clinical trials, and NK cells, they don't care about, I mean, they express or they look at antigens which are universal. They are expressed on a number of cells. So the construct we have in clinical trials here, and that is looking at the NKG2D ligand, which is expressed on lymphomas, leukemias, myelomas, liver cancer, breast cancer. So it's a phase 1 study, which is cancer agnostic. And what they've done is they've taken those off-the-shelf NK cells. These are donor NK cells where the NKG2D ligand is overexpressed. Okay, so they've used the CAR technology to overexpress those NK cells, that ligand, that specific ligand that is overexpressed in these tumors. And they've also put in an IL-15 pump into that NK cell. And what that does is that NK cell tends to persist for a few weeks versus a few days. So I give you this as an example because, I mean, now that you have the technology, and we even haven't talked about the CRISPR stuff, right? I mean, this is going to explode over the next 5-10 years.
I think those are all the questions, Dr. Navaneet. Thank you for this excellent presentation and the discussion. Over to you, Dr. Shinto.
Thank you, Dr. Majhail, for that very lucid talk. So when I was in Seedman, when I saw that Clinimax Prodigy machine, I thought it's very easy. You get the machine, you get the lab, and you get the cards. But looking forward, I think India is also in the right path, led by TMH and all. So soon we'll have affordable and accessible card to eligible patients. So with that note, I thank Dr. Majhail and Dr. Hasmukh, Dr. Akansha, Dr. Nisha, and Dr. Rashmi for joining us. So we all this session is a wind up. So I will proceed with the vote of thanks. So we all had an excellent evening tonight. So we had 6 talks, all were equally good, all presented by the stalwarts in the field. So I would extend my thanks to all the speakers and all the moderators and the panelists, my seniors and my colleagues, to make this event a huge success and a huge academic. We all learn from you. Thank you for joining us. Thank you each and everyone.